All right, let me begin. Hello, attendees. Thank you so much for joining us today. This is another webinar in a series of webinars being presented by the USA TV Care 2 team. We are also going to be hosting other webinars in the following weeks on IPC, Comprehensive Supportive Care for People with DRTB, Community-Based DRTB Care, and also Digital Technology for DRTB. Today's webinar, Advocacy for Implementing Comprehensive Supportive Care for People with DRTB, being presented by Darcy Richardson and Lisa Adams, and I will hand it over to them to begin.
Okay, thank you very much, Sharanya, and welcome everyone who's on the phone or internet or however you're connecting. Sharanya, I just want to let you know that Charles is not connected from China, and I have not received any email from him, so I don't know if he's having trouble connecting or not.
Okay, I will reach out on my end.
Okay. And his is the name that begins with a Z on that email list. Xijang, okay? If you need any help. All right, welcome everyone. We won't delay. Thank you for joining us for this last in this series around the comprehensive supportive care package for people with drug-resistant TB. This webinar is going to be about advocacy, and I want to go through just a few background slides at the very beginning to remind you about the framework for the comprehensive care package. And then I want to turn it over to our country participants who have experience on the ground in doing advocacy work around the care package. Next slide, please. So in this webinar, we're going to have a quick overview again of the comprehensive supportive care package. I'm going to talk very quickly about general considerations for advocacy. We're going to hear some success stories and get some advice from the 4 pilot countries involved in our work. That includes China, Pakistan, South Africa, and Ukraine. And then Lisa Adams will talk about what data should we collect to make a compelling advocacy argument. And then we'll have some time for questions and answers. So I just want to remind you, when we're talking about quality care for people with drug-resistant TB, we're talking about a whole universe of different activities that go into making up quality care. What we're going to talk about specifically in this webinar and what we've talked about in this series is one element of quality care, which is supportive care until cure. That cannot happen in isolation. All of these other elements need to be in place as well to be delivering comprehensive quality care, but we're specifically focused on the supportive care that should be provided. Next slide. And just I want to mention that you will have access to these slides after the presentation, so don't you need to take detailed notes right now. There are 4 thematic areas in our framework for comprehensive supportive care: respect for patient autonomy and self-efficacy, maximizing physical comfort and safety, providing psycho-emotional support, and preventing catastrophic cost to families. Hit another couple of, yeah, let's put all those up. Thank you, Sean. And one more. There we go. Great. So within the framework, we have 13 comprehensive care elements, and these represent all of the various areas that patients have expressed a need for or a desire to have access to as part of their care for drug-resistant TB, and I would say for tuberculosis as well. That these elements are important to address in thinking about how to best support patients through care. So this is the framework that we used in doing this pilot, and it's the framework that has been used in the 4 pilot countries. So this is what we're talking about when we're talking about advocacy efforts, and some of you probably have joined our previous webinars that discuss how to implement this in detail. Now we're going to focus on the advocacy component. Next slide, please. So when we're talking about advocacy, what are some of the things we need to talk about? The first is you're doing advocacy, you're asking people to change something. So we have to define very clearly when we're thinking about an advocacy campaign, what is it we're trying to change? And then who are the stakeholders that can make that change? And it's usually decision makers. It could be decision makers at a very local level. It could be at an individual level. It could be at the local community level. It could be at a facility level. It could be national. So think about who your stakeholders are you need to engage in this process. Then what messages are going to convince them to make the change? So why should they care about this issue, and how can you craft your messages to speak to what their concerns and needs are? And then who are the people best placed to deliver those messages? In many cases, we find that people who have gone through the experience of being treated for tuberculosis or drug-resistant tuberculosis are really the experts and can deliver a message that is both personal and compelling to decision makers. And then what other stakeholders can support us in advocating for change? So do we have other partners who could provide additional support, or who could reach out to other communities? And then when should we advocate for the change? So at what point in the cycle of planning and budgeting is it useful to engage with stakeholders to do advocacy? And do you have any other things going on, like the annual World TB Day, that would be good times for advocacy? Next slide. And Sharanya, I just wanted to tell you that I just got a message from Charles saying he's still trying to join. So in operationalizing the package, we do so at the global level, the national level, the local level, and also at the individual patient level. And at each of these levels, we might have different stakeholders for advocacy. Can you hit the down button again? And 4 more times, yeah. So at each of these levels, we have different audiences perhaps for our advocacy. At the global level, it might be WHO or our donors, country leaders. And then at the national level, when we're trying to do advocacy around the care package, it might be, the audience might be the national TB program manager or elected officials, people at the Ministry of Finance who can provide money to implement the care package. At the local level, we have the local NTP managers and stakeholders, local government officials who might have to pass some sort of precause or order or legislation to allow the care package to be implemented. And then when we're talking about implementing this at the individual patient level, it might be individual care providers we're trying to do advocacy with to adopt the care package. So the point is, think about where you're trying to do advocacy and who will your target audience be. Next slide. Now we're going to go to our presentations from the countries. They all had a lot of different experiences in implementing the care package and approach advocacy in different ways. So I want you to hear them talk a little bit about what their advocacy challenges were and how they addressed them. So we will start with Pakistan, and we are fortunate to have Karam Shah with us today to present on their experience in Pakistan. So I will turn it over to you, Karam.
Thank you very much, Darcy. Good evening here, everyone. I'm honored to represent Stop TB Pakistan and National TB Control Program, and just share our very brief experience and then some thoughts. So can I have the next slide, please? Yeah, as Darcy was referring to the stakeholders, I think that maybe it's there are a few general principles, but then maybe you can adapt it into country context. In our setting in Pakistan, of course, the Ministry of Health is on top of the stakeholders or the target audience, as Darcy was referring to, because everything when it comes to the health moves around Ministry of Health. But then to get Ministry of Health on your side, and then the Ministry of Health would support you to approach and do some sort of advocacy on the political leadership. In our case, it's a democracy, it's a parliamentary system. So we have upper house and we have lower house. So we started basically knocking doors of both the houses, and not only here but in the provinces also. So we have health standing committees of the parliament who deals with all health. So we brought in the MDR and the TB as a general case to the leadership. Of course, we understand that the corporate sector and philanthropists, they are very rich in Pakistan, and there are so very good examples of the corporate sector and philanthropist offering the services, health services. Then technical and development partners, WHO, like Stop TB Partnership, and within country development partners, of course, USAID country mission is always on our side. So what we understand, there is a list of the, I would say, wish list where do we want these partners to be engaged. But the prime, our objective was basically to mobilize the domestic resources to sustain this comprehensive package. Next slide, please. Right. So to be honest, basically, advocacy is a simple to say, but it is not very easy because it's a dynamic process, and it needs basically lessons to be learned in the field when you start. Sometimes you feel quite disappointed because you go to the people and they don't listen to you. So we try to find what are the best tools to draw the attention of the stakeholders, which I mentioned. So we found that the TB survivors and the community CSOs, civil society organizations, human rights activists, and journalists and celebrities, we found these are the best tools who can easily draw the attention of those where we usually can't go. So then, of course, they are the people. But I mean, TB survivors, CSOs, human rights activists, to bring to a strong voice, we need social, electronic, and the print media. So journalists and celebrities, they are the people who take the TB survivors and the CSOs, and they bring the voice. And I want to mention here basically a very good opportunity which we found during this package. The Global Fund has a window whereby they build the capacity of the CSOs and the TB survivors and enable them to have this advocacy tool, a very strong advocacy tool. So I thought it will be very good to share this our experience and information. I believe that most of the countries who are I mean, implementing this MTR package, and in future also, they are eligible for the Global Fund. So if you are eligible for Global Fund, try to approach the Global Fund, and they will basically offer you the technical assistance, and that technical assistance you can use to equip the TB survivors, CSOs, and human rights activities, so that basically they can portray and they can showcase your case in a nice way. So so we are doing it, and luckily Luchika will be in Pakistan day after tomorrow with Peter Sands, with the Global Fund Executive Director, and we will be showcasing this MDR package case, success stories, challenges, way forward, and the ask from Global Fund and Stop TB Partnership during their visit. So this is this will be one of their key activity whereby we will be bringing TB survivors and journalists to. So what I'm saying is basically it's a dynamic process, advocacy. So don't be disappointed if you go to the parliamentarian, to the policymakers, to the Ministry of Health, and that they don't listen to you seriously. So again and again, it's a basically breath holding exercise. Be patient and bring all these tools, I mean, the activists on your side, and at the end of the day, they will start seriously talking to you about TB, talking to you about MDR, talking to you about package. So I stop here, and then I'll be happy to respond to any question. Darcy, over to you.
Okay, thank you, Karam, very much. Next slide, please. Because I think you have one more slide, Karam, if you want to.
So this is all basically. I thank you very much, Darcy. So on extreme right, you see a very famous celebrity, She is a TV drama actor. And then you have a journalist in middle, and on left side, basically these are the groups, the civil society organizations, activists, transgender, the musicians. We brought everyone during TB Day, and we presented this MDR package to them, and there was a group work exercise, and then all these groups brought forward 1 year activity plan, and that activity plan is being implemented. Thank you very much, Darcy, for drawing my attention.
Thank you very much. I think that's very interesting, Karim, and I really appreciate that you mentioned Global Fund and how you have brought in not only local stakeholders, but also international stakeholders who can help you make the case. So next slide, please. Now we're going to move to Ukraine and talk about some advocacy that was done at the local level to try to convince providers and managers to implement the care package. So I will turn this over to Svetlana Okromeshko.
Hello, everybody. My name is Svetlana Okromeshko, and I am a consultant for the Challenge TB project in Ukraine. In Ukraine, supportive services for the RTB are funded by USAID Challenge TB mechanism that is implemented by PASS 2015 and also the Global Fund. Most DRTB loss to follow-up occur in the ambulatory phase. Therefore, first we focused on support of DRTB patients at the ambulatory stage in 2 provinces, 2 oblasts, then expanded services to 6 oblasts, and then finally in 2017 added an inpatient component for comprehensive care of DRTB patients. To implement this work, we needed support of the head of Oblast Health Department, head of Oblast TB services, chief doctors of medical facilities, and also medical providers. Since support to TB patients was provided before our project with poor results, we had to convince decision makers to support care package implementation and demonstrate different approach, that supportive services are not isolated activities from the treatment process, and then they can reduce loss to follow-up and result in significantly higher treatment results. With leading role of the Oblast TB program, we united efforts of TB services, primary healthcare, and NGOs and developed the strategy of social and psychosocial support for patients with the RTB, and developed interventions, next slide please, and developed interventions based on the thorough situation assessment and barrier analysis of problems that prevent the RTB patients from completing their full treatment course. So sharing project results from Oblast where the care package was already implemented was crucial. We conducted meetings with decision makers and project partners to demonstrate how psychosocial support contributed to TB control targets, invited them to attend conferences and visit project sites that achieved significant results to exchange experiences. Also, conducting meetings on conducting a variety of tailored trainings for hospital staff, local NGOs, and multidisciplinary teams help us to get TB service providers' commitment and facilitate the effective cooperation with other partners. Next slide, please. The strategy and the other tools were handed to the National TB Program, and the RTB package implementation results were presented at the national level. At present, there is understanding on the important role of supportive services. The DRTB patient assessment and care plan in the hospitals will be included in the guaranteed service package as part of the government budget and formal guidance. Considering decentralization of the overall system in the country, all real resources are now located at the oblast and community level. So other supportive services at the ambulatory stage, such as food packages, legal support, etc., will be provided by NGOs and funded by local authorities and donors. So it is very important now to join efforts to do good advocacy campaign at the local level so that the resources are allocated in the local budget. We led several roundtable discussions for medical community and Oblast decision makers to advocate for community needs to be integrated into Oblast administration budget. Also, in some Oblast, project partners united their forces to secure sustainable funding for NGOs to continue their work. For example, at this photo, you can see the meeting of the head Oblast TB services in Lviv Oblast, Deputy Director of Health Department and NGO representatives. They united their efforts and they met with the Deputy Head Oblast Council and Deputy Head Oblast Administration. And in Lviv Oblast, patient support strategy at the ambulatory stage will be incorporated or is a part of the Oblast TB program. And Oblast administration is committed now to allocate some funds for this work. Thank you.
Thank you very much, Svetlana, and thank you for making the point about the need to engage your local stakeholders, especially in the context of decentralization when local stakeholders are the ones who are allocating budget. Okay, next slide, please. Now we are going to move to South Africa, and Princess Mabota Rafolo will be giving us a short presentation on what advocacy has looked like in South Africa. Over to you.
Good morning, everyone. Good afternoon, everyone. I'm going to share experiences from South Africa. Next slide, please. So within our context, we had advocacy and buy-in meetings at different levels with different stakeholders. Our first point of call was with the NTP, and we engaged with them to discuss the supportive care package in detail. Then following that, we had meetings with provincial and district DRCB managers. And these meetings, we included facility CEOs, nursing services managers, and clinical managers of pilot facilities or hospitals. The purpose of this meeting was to engage with them, and we used them to review the DRCB performance, the facility, as well as the district performance. And we also saw it as an opportunity to assess the availability of resources, both human resources and the systems resources. We also established our multidisciplinary teams from these meetings. So at the end of each meeting, there were agreements that we came with to make sure that there is follow through and there are action items that needed to be addressed. Following that, we had orientation workshops with multidisciplinary teams, and we used those meetings to discuss the standard care package, to see how it looks like. We also engaged on the thematic areas and the essential elements and looked at what would work best for South Africa. We also agreed on which cadres will be responsible for which element of the care package. Next slide, please. Importantly, we engaged with our project-funded NGOs, and these are at the core phase of service delivery. Our NGOs, they work with the patients on a daily basis to provide them with adherence support, to support them with and educate them on TB and also on other issues. So it was important for us to engage with them because they were our biggest stakeholder. And that's why we identified our DRCB nurses and their roles, for the clinical management of patients, for the social workers and their roles, which was focusing on nutritional and psychosocial support, as well as our community health workers from our funded NGOs for adherence and patient and family education. Next slide, please. And in terms of advocating for scale up, I think it was a bit easier because now we had implemented the pilot. We had also had our own internal meetings and internal workshops to give feedback to our stakeholders. We also use this meeting, as you can see the picture, we also use this meeting to invite other districts to participate and also get the lessons learned. So we went back and we shared our lessons learned with the NTP and our original stakeholders. And we are using, or we used other platforms such as the DRTB review meetings that are taking place at provincial level and at district level. And what has been important was, that feedback from the feasibility and acceptability survey, the patient experience survey, and also the experiences of former recipients of the supportive care package. I have to say that it was easier because now we know what the package, at this stage, we know what the package looks like. We know what resources are required, and we are using we're using our experiences from the service package to incorporate, the whole process into the comprehensive DRTB decentralization support. Next slide, please. And an important element are the engagements. Here we can see there's a picture that we took with Dr. Lisa and Dr. Hilton when we did a facility visit in one of the pilot sites in Limpopo. That's Matala Hospital. And there was a walkabout. The lady standing with Dr. Lisa and Dr. Hilton is Dr. Miso from Matala Hospital. Next slide. Oh, thank you.
Thank you very much. And I think Princess made a couple of very important points about thinking in terms of what's happening in the broader health system and thinking about decentralization as an opportunity to integrate the care package into guidance and into funding, and also the importance of sharing data back to the people who are participating in the pilots and to decision makers as well. And now we are going to go to our last country experience in China. And I will turn this over to Charles to walk us through the advocacy efforts there.
Okay, everyone. And now I will let you know more about what China has been doing, the lessons learned when we scale up the comprehensive supported care all over China. Now this is the second year of national scaling up at the comprehensive supported care. Everything is going quite well, and as we try to replicate the model in more provinces, it bring us some good experiences how we can make this model really benefit the many MDR-TB patients in China. Next slide, please. So I will focus more on the strategies, how we advocate and to make this model to be accepted by the Chinese government, and so that it could be replicated to the greatest extent to reach more provinces. And the first one for us, we think it's important to engage the existing, leadership from the China National Center of Tuberculosis. This center is under the China National CDC, and also we try to engage the Provincial Center for Disease Control and Prevention, and all these, the national and provincial CDC, they were engaged in the project design, in the training, implementation, and evaluating process. So they know what really happened and how it can work at the local level. They joined the working group meetings with the site partners, and they know what's going on, and they conducted a quality, monitoring, and so they know what kind of quality and standards should be met when they try to replicate at the new site. So you can see that if we engage them all the way through and we see greater ownership and the national commitment, and which make it much easier to replicate the model in more provinces. The second one we think is quite important is that from the national pilot of delivering this comprehensive supportive care, we started to try to make full use of the program data, and so to make it as a powerful tool and to conduct evidence-based advocacy, because really now the Chinese government really wants what they do is really data-driven, so that this from all the demonstration site, we try to provide TAs so that they could generate reliable data to show to the government that this comprehensive supportive care model really work. And for CAP-TB project in China, we developed a clinical management platform. This is a very easy and very efficient electronic platform that can be used in MDR TB care facilities that is replicating the comprehensive supportive care. So all these data from this platform showed improved enrollment, retention, and treatment success. And one thing we feel that if we conducted patient satisfaction surveys, and these surveys also showed high levels of satisfaction from the patient themselves. They are satisfied with what they have been provided. So this provides evidence to the government that, oh, this is something that really work, and we can do this. So that's why we see increasingly more buying from the national and the local governments to support our model. Then all those, the sites who have been engaged in the national pilot to deliver the comprehensive supportive care, we found some of them are very highest function pilot sites. We use them as demonstration sites, and they could conduct, organize, they can host the program visit for the public health officials from the new province. They can learn more about it, this model, so that we can desensitize the health officials and let them know more how it may work. And also these demonstration sites can be very helpful to work as, to organize the practical workshops for some newly trained counselors to know how they may work in practice. And so they can work hand in hand with the nurse counselors who already have experiences with how to translate it, the theories into really cares and for the patients. So based on that, and we see that there are more national commitment from the government. So we signed official MOU with the China CDC. I think it's very important because it really legitimate the commitment, legitimate the national scaling up. It's the national ownership of the programs, and also it really work well if we have official, MOU with China CDC, and so it's make it very well for this model to could be replicated using the top-down model, the Chinese efficient and hierarchical system, so they can reach the ground very easily. after that, in
Sorry to interrupt. You have about 2 minutes left.
okay, yeah, and so we can great support engagement at the provincial and the local level, and so that we can. That's why we get 50% domestic cost sharing to support training and on-site TA for scale up. Next slide. So you can see in Zhenjiang site, we see there's more community because they think that it really work over there. So integrated this care package into the next 5-year action plan in its province, and we see that now the provincial government has started to replicate this model to in 10 more sites. Next slide. So I've just said what I try to say in this slide, and we try to advocate to the government no more through the national meetings and national teleconference, and we prepare the tools and do the documentations so that these tools will be used by the local resources to provide training and also train the local TA providers to be advocate for models. Then we try to apply this package into the national SDR pilots. Then now we are moving to the second wave of the national scaling up. We have already scaled up this comprehensive disability care to 9 provinces in China. We are now moving to the second wave, and with another 4 provinces to be covered. That's it. Thank you.
Thank you very much. I really appreciate it. And I think that a couple of the points that Charles made around the early engagement of your stakeholders and their participation even in the design of the project is incredibly helpful in getting, in promoting ownership and buy-in, and also the use of data to convince your stakeholders that this is a worthwhile investment, which is what we're going to talk about now. So if we could go to the next slide. Lisa is going to talk a little bit about monitoring and evaluation and how you use data that you collect for advocacy purposes. And we're going to talk a little bit about what we did in the pilot, and how you might think about collecting data to make the case for implementing the care package in your settings. So I'm going to turn it over to Lisa.
Thank you, Darcy. So that's absolutely right. I think we think of monitoring and evaluation data as being used for project implementation and refinement and improvement, but I think it's important to remember that we can also be using these data for advocacy. And I think the 4 country team representatives did a really terrific job of showing how they have used their data and their experience for advocacy purposes. Next slide, please. So again, just to highlight the point that M&E data can be used for advocacy in terms of both identifying gaps in care in your setting, and particularly gaps in care that may be priorities to policymakers. But it can also be used to demonstrate the benefits of the supportive care package and how it can lead to things like improved quality of care, better patient adherence and eventual treatment outcomes, greater satisfaction for both patients and healthcare workers, as we'll talk about, and improved cost effectiveness. I think one underlying theme to keep in mind is to always be thinking about collecting the data that are going to help you tell your story. I've been sort of focused on thinking about data that would influence local and national policymakers, but it really can be used for at the other 2 extremes too, for international level advocacy or for local advocacy and community mobilization. But thinking about which data will really help you in telling your story and making your case is going to be important. Next slide, please. So I'm going to share a little bit about what we did in the pilot, and and it's important because these are also tools that are available in the care package toolkit. So these are already have already been prepared and are available. So we of course assessed patient care and patient satisfaction, and we did that using patient surveys, comparing the pilot group to a control group, a group that hadn't received care under the care package, either at the same facility or at a different facility, and tried to determine things like, does the care package lead to greater patient satisfaction? And are critical patient needs being addressed, particularly care around adverse drug reactions that patients may be experiencing, and their psychosocial needs as well. We also felt it important to assess the package feasibility and acceptability, and we did this by surveying healthcare managers and frontline providers, and asked the program managers whether they felt that implementation of the care package was feasible. And perhaps more importantly, asked the frontline workers whose input and buy-in is critical, whether they felt support of the care package could be sustained over time, and whether they supported implementation of it. And so those were again key things that may be very important to policymakers in terms of feedback as you're thinking about implementing the care package. Next slide, please. So we then also assessed the perhaps critical outcome of clinical outcomes for our patients, and for this we had to use program data. So we looked at the outcomes of our pilot cohort and compared those to program data from prior years. And we looked at whether the care package could lead to improved treatment outcomes, and particularly whether it improved treatment success rates and led to fewer deaths and loss to follow-up in the patient cohorts. And then our team also performed a cost analysis that measured the incremental costs of providing the care package services in each country. This was based on project budgets and discussions with the actual implementers. And then lastly, we also ran a simplified model to estimate the number of patients with a favorable versus unfavorable outcome under both standard care versus supportive care package scenarios, and then calculated the associated costs. Next slide, please. So here are some of the results from the pilot that we conducted. And again, just data that we think could be useful for advocacy purposes. So this graph shows the overall patient satisfaction with the DRTB care package. And you can see in several countries, I don't know if my mouse will show up on the Zoom link, but looking particularly at China, Pakistan, and Ukraine, implementation of the care package clearly improved patient satisfaction with their services, sometimes by a smaller amount and sometimes, as in Pakistan's case, quite substantially. Now, in South Africa, you may note that the results showed a slight decrease in satisfaction with care package services, but this decrease did not translate into worse outcomes. And we think it's important to always examine and explore unexpected outcomes like this. And several possible explanations exist for the case in South Africa. It could have been that the pilot sites had very high expectations and were therefore willing to be critical of their care, or that there may have been a sample bias in the comparison group favoring those who were already satisfied with their care. Interestingly, in all of the countries, we noted that it was things like one-on-one counseling and various forms of economic support that patients cited most frequently as the interventions that they felt most helpful to ensure their treatment and adherence, and with which they were very satisfied. So again, pulling these data to try to think about how you would use this to advocate amongst policymakers, and again, showing improved satisfaction is certainly could be one criteria. Next slide, please. So these two graphs show the results from our feasibility and acceptability surveys of managers and healthcare workers. So on the left, you see that when we asked providers about whether they found their work to be more satisfactory, overall, providing the supportive care package left providers and staff feeling more gratified with their work. some of their satisfaction seemed to come from the fact that they overwhelmingly reported that they felt the care package helped their patients better adhere to their complicated and lengthy DR/TB treatment. But again, we're looking at upwards of 70 to 80% of healthcare workers reporting higher satisfaction levels. And then on the graph on the right, we asked about whether the frontline healthcare providers felt that this effort was sustainable. And you can see that the majority of managers in Pakistan, South Africa, and Ukraine thought that ongoing implementation was feasible. In China, the managers were a little bit less confident about maintaining the package after the pilot, and that may have been related specifically to their circumstance and uncertainty about ongoing funding of these activities. Next slide, please. And now the clinical outcomes, again, as the really key indicator for showing impact of the care package. So this table, it's a little busy, but it shows the comparison of the historical cohort and the pilot cohort outcomes for each country. Now, I just have to point out that because our pilot and follow-up of patients only lasted 6 to 9 months in each country, we had to rely on comparing interim rather than final outcomes. However, in all of the pilot countries, the interim outcomes for patients receiving the care package were superior to the final outcomes of patients on standard care. And for example, if you look at treatment success rate, the first one outcome in yellow, and follow along across the countries, you see that in China, where the historical outcome had been 42%, the pilot outcome, again, as the interim outcome of those still on treatment at the conclusion of the pilot, went up to 88%. In South Africa, 53%. And because we had some patients on the short course treatment, we were able to get final outcomes for some, but a combined 65% treatment success rate projected. Ukraine up from 48% to 83%, Pakistan 74%, up to 95%. And then if you were to follow along for these other outcomes, treatment failure, died, lost to follow-up, you can see sometimes dramatic decreases in these unfavorable outcomes for all the countries. So again, these are, I think, are key data that could be very useful to an advocacy effort for encouraging policymakers and others to adopt the care package. Next slide, please. Now, we know that policymakers are always interested in costs. And as I mentioned, we measured the incremental costs of providing the care package in each country. And these are shown here. Now, one thing to note is that because countries provided different interventions and included different items in their cost estimates, these estimates should not be taken as a direct comparison, but rather sort of as a relative measure of providing the care package in each of the 4 countries and their particular pilot sites. But as shown here, cost per patient per month varied from approximately $40 in Ukraine up to $148 in South Africa. And again, policymakers are going to want this kind of information. I will just also lastly mention that we also did the estimated associate costs and savings based on patient outcomes under both standard care and those receiving the supportive care package. In the interest of time, I didn't share those data, but can report that in all countries, implementing the comprehensive care package was shown to save lives and improve cost efficiency. And more details about that analysis are provided in the final reports. Next slide, please. So in conclusion, using your data to your M&E data can improve care and be used for advocacy. Just some reminders that I'm sure you're all well aware of: the importance of reviewing your data frequently to address issues that come up and be able to refine the package and the interventions. To use your data to be able to demonstrate the key factors of improved care, acceptability, and clinical outcomes. And again, those tools are available to help you do that in the care package toolkit. And to be able to target the priorities of policymakers so that you can use these data to advocate for allocation of resources. But then lastly, never forget to share and discuss your data with those involved in implementing the care package, because some of your frontline providers and even your patients may serve as some of your best advocates in this effort. Next slide, please. So I'm going to conclude there, and I'm going to add my thanks to everyone involved in this project, many of whom are listed here, but of course there's even many others. And I will turn it over to Darcy, I think, for the last slide.
All right, thank you very much, Lisa, and thank you to all of our presenters. I really appreciate all of the work you did to put this together. I think we have a lot of really good advice for other countries who are thinking of implementing. This is the team that put together this pilot, and I really want to say thank you again to the countries and the national TV programs and our partners in China, Pakistan, South Africa, and Ukraine, which include FHI 360, the Stop TB Partnership, URC, and PATH for their work on this project. Next slide. And just so you know where you can go to get more information, the final report, which is, there's a summary report, and then there are country reports specifically on each of the pilot countries that include a lot more discussion of the data and the costs, etc., are available on the Development Experience Clearinghouse website. These are the addresses for the documents. So there's a final report. You can get all of them there. And we also have the toolkit, which provides guidance on how to implement at country level, with a lot of different tools you can use to plan and implement a care package. And that's also available on the deck. So please feel free to access those. Those are free to download. Next slide, please. And now we have a few minutes left for questions and answers. I know we had a couple of questions come in on the Q&A board that I answered while Lisa was talking. So the first question was around M&E surveys, and did we need ethical approval to approach patients, or was this under quality improvement? That's a great question. The answer is that we did ask for ethical approval for our pilot study and got that at the national level in all of the countries where we worked, so that we were covered for all of the information we wanted to collect. And you can easily do this as part of quality improvement in a programmatic setting, but since we were doing this across 4 countries, we felt it was important to get the ethical approval. And as you asked, Ravandi, it was at the national level that we did this, not at the facility level. But are there other questions? You all are free to type it in, to raise your hand and ask it verbally, whatever is easiest for people. If anyone has any questions, and you'll see that there's a poll up with an evaluation. If you would be so kind as to complete that, we would appreciate it. But we're here to answer any questions that you have. We have about 5 minutes left if anybody has a question they'd like to ask any of our presenters. I'll give you a couple of minutes to.
Darcy,
Yes.
it's not a question, if you allow
Yes.
me.
Yes, please.
Thank you. Just I wanted to refer back to my presentation, whereby if any country is interested to bring this technical assistance for capacity building of the CSOs and the communities, so that this set of our activists could play an important role when the countries are making their next Global Fund grant.
Right.
So that these, I mean, they will be, their capacity would be built through this technical assistance of the global. Me and Darcy, we wanted to bring Hee-Yong Lim, who is basically the desk in charge in Global Fund for this technical assistance, but anyway, we can coordinate. So this is the good time, because most of the countries are now would be planning to submit the new Global Fund grant. So that would be definitely helpful. And then these communities can play a very good role, and they can ensure that the next grant includes this comprehensive package.
So Karim, maybe you can talk a little bit about how a country would go about asking for that technical assistance. How did you access that?
Yeah, in fact, I had a chance to meet the portfolio of the Global Fund during their visit here. And then we talked basically about the gap in demand creation. And that gap is because, I mean, we all know that TB community is not as smart as it was HIV. So we wanted them to help us and build the capacity of the activists, the CSOs, so that they can play an important role and bring that voice in the Global Fund. So they happily agreed. So there is a special desk for this technical assistance. So I can share with you the link, and they can go to that, and we can coordinate with Hyong Lim, who is very much committed, and she was about to join us in this link also, but could not do that. And she would be, I'm sure she would be happy to help and respond to the questions of the country.
And so what is the group, what is the name of the group in Global Funds that does this, that provides this technical assistance?
Sorry, Darcy, I could not hear you.
The name of the group within the Global Fund.
Yeah, it's a CRG. I think it's a community something for the Global Fund. So I can do it right now.
I think it's Community Rights and Gender, or
yes, Community Rights and Gender. Yes, exactly.
Okay, so yeah, if you could share that, that would be really great. And so after, well, maybe Sharanya, I think since there are no questions, maybe you can wrap this up and tell people how they'll be able to.
Yep, thank you for that.
Hold on 1 second.
Oh, we have one more question.
Yes, I can see that. Can you comment more on sustainability after the pilot period, funding available to do this? Is it reliant on further Global Fund grants, and how are CSOs identified? I don't know if you're asking specifically about Pakistan. Maybe Karim, you can answer that question. Are you still with us?
Yes, please, Darcy, I could not hear you clearly.
Okay, there's a question that was typed into the Q&A section that said, can you comment more on sustainability after the pilot period? Is there funding available to do this? Is it reliant on further Global Fund grants? How are CSOs identified?
Yeah, in fact, in our case, there are different windows. What we are doing next week, but rather this week, I am meeting with the USAID mission. Han Kong, he was kind. I requested him for a meeting so that I can present this comprehensive package, the outcome, and I think this Lisa's slides are wonderful and they are quite helpful. So this is one window. I mean, you can go to your country mission, and I believe that those countries who are still in a NAP can get the benefit of that. Global Fund is another opportunity for us. And in our case, because it is a devolved system and all provinces have their own finances, so we are basically taking forward this message and the outcome, of course, the evidence to the provinces, and we are pursuing provinces to bring at least, we know that, I mean, there are about 130 districts. We cannot do this comprehensive package in the whole country, but we are pursuing them to at least scale up in a couple of districts in each province. And by next year, we will get it done through the domestic funding. So it all depends on basically how smartly you, educate, and of course, play on the evidence and the outcome. I mean,
right. And I think CSO identification has been different in all of the countries, but a lot of course, there's always, things have been going on in countries. It's not just we're starting from scratch. So a lot of countries have identified CSOs to work with through partnerships that they have established previously.
Look, Darcy, just basically, I want to, what we found, and this philanthropy and the corporate, this charity business, When you go to them and ask for the catastrophic cause, catastrophic,
Right.
it's a basically very sensitive word. And we tell them, look, I mean, your MDR patient in your area, your industry, your district would die because he cannot afford coming to the center. He cannot afford basically nutritional support. So they are, and we are about to pilot this the social support part of this comprehensive package in one of the districts in Sindh with the help of provincial minister.
Very good. Very good.
It will all be done by the corporates.
So I hope that answers your questions. We have to go now because our hour is up. So I will turn this back over to Sharanya.
Hi, everyone. Thank you so much for joining us today. Thank you to all the presenters for leading such a great webinar. A friendly reminder to all attendees, we are hosting another webinar tomorrow at 9 a.m. EDT time on reducing TB transmission amongst healthcare workers. This webinar and the presentation will be available on tb.academy. If you have any questions, please feel free to email us at tbcare2webinars@urc-chs.com. Thank you so much, everyone, and have a wonderful rest of your day.
Thank you. Thank you so much.
Thanks.
Thanks to all the presenters.
Thank you, Sharanya. Thank you, Darcy, for your determination, and you are very strong.
Yes, thank you.
Thank you. Thank you, everyone.
Thanks.
All right. Take care. Bye-bye.
Thank you, Darcy, everyone.